The Remeex adjustable sling, I think this is what sort of they were known for to me. This is something that's been around now for 20 years, was approved in the United States about 10 or 12 years ago, many publications, and there's follow-up out to about 15 years on some of these patients. And the interesting thing here, it's placed just like a traditional transvaginal rectopubic sling. You pull up the suture, it's got a small area of mesh here, and then the interesting thing is this device is placed right against the fascia. This, almost like a little wrench, is brought out through the incision or through a separate little stab wound. And then the following day after surgery, the patient comes into the office and you can actually tension it. It sort of pulls it up like a fishing spool based on what the patient's experiencing. So you fill the bladder up, have the patient cough. If they leak, you give it a few turns until they don't leak. The patient starts to leak again. In the office, you just prep the suprapubic area, make a small incision, find this little area, and then you take a fresh little one of those screwdrivers and you can actually either make it a little tighter or a little looser. So it is something that's very adjustable.
As you go through these studies, you start to see a recurring theme, which is regardless of whether this is used in a salvage case or really a severe case, someone with ISD, there really is a significant improvement overall with very few failures and actually very well tolerated with very few side effects or complications.
I have very similar complication rates compared to the traditional TVT with higher success rate because I can adjust in time the tension, and significantly lower voiding dysfunction compared to traditional pubovaginal slings. So those are all the reasons why the more complicated patient is, the safer I feel offering this type of procedure with an adjustable Remeex slings to address patients' incontinence. Recurrent incontinence is treatable with this procedure, and you don't have to add with your treatment other comorbidities like voiding dysfunctions, urgency, frequency, or urinary retention. And we know how this is.
So my experience with all this goes back in the 1980s. I started doing autologous fascial slings. Great operation. I still utilize it. However, there is morbidity to that. In the 1999s, I moved over to TVT as things evolved into TOTs and really single incision slings within the 1997 era. And then it was really, I've been in the same location for the last 27 years. And when you're in the same spot for 27 years, your patients will come back and you start to realize that, wow, some people are having recurrences. And so that's when, in 2016, I started looking at the Remeex sling, because could that be the answer for some of these patients who have immobile urethras, recurrent stress urinary incontinence? So who are the candidates in my mind for this type of sling? For my situation, it's really for someone who has recurrent stress incontinence, mainly recurrence from a retropubic midurethral sling. Someone with a TOT, I may potentially do a retropubic sling in that situation. But the ones that I find the most are really the non-mobile urethra, ones that have poor urethral tone. In addition, people who have maybe chronic coughs, tracheostomies, people that are really aggressive coughers because I want that dynamic transmission to hold that in place. Additionally, patients who are large and high BMI. And then the underactive bladder is always a difficult patient because they balance between incontinence versus continence versus voiding dysfunction. There's a very small, narrow window, and so that patient is one that I sort of choose. So the other key thing about this is the mechanism of action. Remember, this is a circular sling. It's all the way enclosed. And so that there's dynamic transmission that's occurring, that because the veritensor is closed above the rectus fascia, when someone coughs or strains, it's pulling up on the suburethral component. You also not only have the underneath component, but the periurethral arms that really add to that support.
Yeah, so I see them as three options. One is to do an adjustable synthetic sling. Second is to do a fascial sling. And third is to do an investigational intervention, such as, we're doing stem cell injections, we're harvesting muscle biopsy.
In conclusion, the Remeex has shown excellent results, even in the difficult patient populations. The success is in part due to the adjustability of the sling. The Remeex sling allows for adjustability, even long-term adjustability. Complication rates, in your experience and published data, do really suggest that compared to the mid-urethral sling or the autologous pubovaginal sling, complications are the same. I would imagine it's much easier to remove a device that really has very little mesh in it compared to removing the retropubic arms of a sling. So that's yet another advantage. The other thing that really seems to be a game changer in your management of these patients is the ability to tension or to tighten and loosen the sling. I think proves that Remeex is an option for the patient with ISD and for the patient with recurrent stress incontinence.